Welcome back guys. Now in this video let's discuss about RH isoimmunization or RH alloimmunization. Guys, this is a very much highly conceptual topic. I just want you to be very much attentive. Don't even distract for a microsecond. If you distract, the concept is going to collapse. Now before discussing what exactly the problem with the RH negative pregnancies, let's talk about a few basics. Let me ask you something. Are you RH positive or RH negative? First of all, what is this RH? Now let's see the basics. On the surface of RBCs, okay, for example, this is your RBC. On the surface of RBCs, there are certain antigens present. These antigens are RH antigens. There are many different types of RH antigens, out of which we are going to consider one important antigen, that is a D antigen. Okay, see, a very important RH antigen is D antigen. Now, if this antigen is present on the RBCs, means it is RH positive, the person is RH positive. If these antigens are not present on the RBCs, means then RH negative. Okay, so what does it mean by RH positive person or RH positive female? We are going to call a female who is RH positive if she has this antigens, D antigens on her RBC. Okay, if on her RBC, if D antigens are present, means then she is RH positive. If there are no D antigens on her RBC, means then she is RH negative. For example, if I ask you what is your blood group, you will be saying, sir, my blood group is A positive. It means you are having A antigen on your RBC along with RH antigen. See, that's the reason why we are showing this a positive. This positive is indicating that on the surface of your RBCs there is this D antigen present. Okay, hope the concept is clear. What is RH positive and RH negative? Now this RH antigen was discovered by Carl Landsteiner. Okay, and this gene for this RH antigen is located on chromosome number 1. Okay, now let's talk about the RH negative pregnancy. What exactly is RH negative pregnancy, guys? See, mother is RH negative. Mother is not having the D antigens on her RBC. Mother doesn't know what is a D antigen. Okay, she is unfamiliar with the D antigen. Why? Because on her RBC surface there is no such thing as D antigen. But her baby, okay, her growing baby is RH positive. Then the problem will occur. Mother is RH negative in nature and the baby is RH positive. On the surface of baby's RBCs, D antigen is present. Okay. Now, why such thing happens, sir? See, mother is RH negative. If partner, okay, mother and husband, mother is RH negative, if husband is also RH negative, there is no problem, there is no possibility of baby being RH positive. If mother is RH negative, father is RH positive. Very important, I am repeating, mother is RH negative, father is RH positive, then 50% chance that she can have a baby in her uterus with RH positive RBCs. So that's what happening here. See, mother is RH negative and the baby is RH positive. Then what happens? What's the problem? By any chance, if fetal RBCs are entering into maternal circulation, okay, by any chance, because of whatever might be the reason, trauma during the delivery or whatever might be the condition. Now, if fetal RBCs, if fetal blood mixes with the maternal blood, just wait. Fetal blood and maternal blood will never mix in a normal pregnancy. If mixing happens, then what happens? Just think logically. Now, mother for the first time is seeing the D antigens, then what mother will think? Mother immune system will think that this D antigen is a foreign antigen. This might be a bacteria or virus. So what mother will do? Mother's immune system will be sensitized and mother is going to make the antibodies against the D antigens. So that the mother is producing antibodies against the D antigens and the fetal RBCs will be destroyed in the maternal circulation. Okay. Now let's discuss what exactly the problem with the RH negative pregnancy. Please follow the flowchart. See, baby's blood is RH positive. Okay, baby is having the D antigen. Now, if this blood, fetal blood, okay, fetal RBCs, if it enters the maternal circulation, what happens? Now, mother's immune system will be sensitized and mother is going to make the anti-D antibodies. Okay. Now, this anti-D antibodies, initially whatever are produced, they are of IgM variety. Okay, we all know that there are different types of immunoglobulins, right? GAMED types. Now, at beginning, mother is going to produce the anti-D antibodies. Now, these anti-D antibodies, they will undergo class switching to IgG type. So, why this is important? See, these IgM antibodies, they don't have a capability to cross the placenta. But these IgG antibodies, which are of very small size, they can cross the placental barrier. Now, these antibodies from the mother, they are going into the fetus. Okay, now they crosses the placenta. Now they enters into the fetal circulation and they starts attacking the fetal RBC. Now fetal RBC are getting destroyed. Now you might ask me, why fetal RBC are getting destroyed, sir? Why? Because these antibodies are produced against the D antigen. Where D antigen is present? On the surface of fetal RBCs. So fetal RBCs will undergo hemolysis. Okay, now in fetus, there is hemolysis is happening. Okay, that's what the problem. Mother is attacking her own babies by making the anti-D antibodies. Okay, that's what the whole pathophysiology here. Okay, now let's talk about a few important points. Okay, because of hemolysis, there is severe anemia. There is no doubt the fetus is going to develop a severe anemia, and this severe anemia leads to a lot of worst cascade of events that we will discuss anyway in a few minutes. Now let's talk about a few important direct single error kind of questions. See, RH negative pregnant female, okay, she comes to your clinic. See, positive females, not a problem. Why? Because they are positive. See, the problem is with these negative females. Negative females in the sense they are RH negative. See, whenever you have a patient with RH negative pregnancy, what you are going to do? First, check the partner's RH status. Check the partner's RH status. Why? Because she is RH negative. If partner is RH negative, no problem. If partner is RH positive, 50% chance that her pregnancy, her baby is a RH positive baby. So always the first investigation to do in a RH negative pregnancy is check the partner's status of RH. Okay. Later. Now, amount of fetal blood required to sensitize the mother. See how much amount of fetal blood is required for the mother's immune system to get sensitized and produce the anti-D antibodies. As little as 0.1 ml. Okay, 0.1 ml is nothing. As little as 0.1 ml of fetal blood is enough to make the mother sensitized, and she is throwing the anti-D antibodies, and these antibodies will cross the placenta and attacks the baby. Now, important concept here is that, see, initially what type of immunoglobulin she is producing, guys? So she is producing IgM. Okay, she is producing IgM anti-D antibodies. Okay, this one. Okay, anti-D antibodies of IgM type. See, these IgM antibodies, for them to convert into IgG, it takes almost 6 months. So within these 6 months, okay, she have already delivered the baby. For example, if this mixing happens by a 7th month, for example, or 8th month. Now for these IgM antibodies to convert into IgG antibodies, if it takes 6 months, already baby got delivered. So first RH negative pregnancy is not going to be a problem. So first pregnancy, okay, RH negative mother with RH positive baby, first pregnancy usually will not be affected. Why? Because by the time mother produces IgG variant of anti-D antibodies, baby is already delivered. So baby is not going to have any type of hemolysis and there is no fetal anemia. First baby is okay. Now just try to think logically. Baby is delivered, but still mother is having IgG antibodies. Okay, mother is having IgG antibodies in her body, in her blood. Now, if second pregnancy is again RH positive pregnancy, these IgG antibodies, now they will cross the placenta, attacks the baby and will kill the baby by hemolysis. Okay, so second pregnancy is going to be affected. Usually first pregnancy is spared. Okay, this is the concept. First baby, not a problem. Second baby, that too second baby should be RH positive baby. If second baby is again RH positive baby, then it's going to be a problem. Now let's talk about what happens with this severe anemia. Okay, baby is developing severe anemia because of hemolysis. What happens? See, there are 5 important consequences because of this severe anemia in the baby. What are they? See, because of severe anemia, severe hemolysis, bilirubin is going to come into the fetal blood. Okay, fetal RBCs are getting destroyed. Destruction of fetal RBCs, it produces the bilirubin. Okay, so bilirubin, which like we know, it's a degradation product of the RBCs. Now this bilirubin is going to cause the jaundice. Yes, baby is going to suffer with the jaundice, and especially high levels of this bilirubin. Okay, more than 20 milligram per dl. At such a concentration, this bilirubin is going to get deposited in the central nervous system of the baby, especially in the basal ganglia. That lead to kernicterus. Yes, a baby with RH negative, like a mother with RH negative pregnancy, if she is having RH positive baby, especially second baby, now this baby can develop kernicterus. True. Okay, kernicterus is a complication because of the accumulation of bilirubin in basal ganglia. Okay, so this is one problem. Now, the second problem with the severe anemia is that now in the baby, too much amount of RBC destruction is happening, but baby want to survive. Now, baby's body will try to compensate the RBC hemolysis by expanding the hemolysis into other hematopoietic organs. Okay, so compensatory extramedullary hematopoiesis is going to take place. Actually, hematopoiesis is the one which is happening in the bone marrow. But now, whenever there is so much demand for the RBCs, like everywhere hemolysis is going on, so you need to compensate. Okay, the baby have to compensate the loss of RBCs. So what baby's body is trying to do? Baby's body is trying to make new RBCs from new organs with hematopoietic capabilities. What are they? Liver. Yes, we know liver have the capability to produce RBCs. Spleen have the capability to produce RBCs. So compensatory extramedullary hepatopoiesis is taking place. So that leads to hepatosplenomegaly in the baby. Okay, so hepatosplenomegaly is seen in a baby with RH positive baby in a RH negative mother. Yes, it's true. Okay, so hepatosplenomegaly is seen. Now, let me ask you one thing. Now there is so much demand for the RBCs. Now, baby's body is trying to compensate the RBCs at any cost. So, during this process, during this rush high demand period, now this liver and the spleen, they are making the RBCs in a very fast pace, and they are even releasing immature RBCs into the circulation. Actually, we know erythrocytes are the mature RBCs. Erythroblast, proerythroblast, normoerythrocytes, like they are immature forms. So during this high demand states, in the process of rushing, there is this release of immature RBCs also into circulation. So remember, see this hepatosplenomegaly during this rush period, high demand period, what it is doing? Immature RBCs are going to be released into the circulation. So that's the reason why we are calling it as erythroblastosis fetalis. Erythroblastosis means it's not the erythrocytes are blasting. Erythroblasts are seen in the fetal blood instead of erythrocytes. Okay, along with the erythrocytes, erythroblasts are present. Erythroblasts are premature forms. So, in the fetalis means nothing but the fetus. In the fetus, you are seeing the erythroblast. Okay, yes. Now, what are the other problems with the severe anemia? Now, this severe anemia, because of this, severe anemia, there is hyperdynamic circulation in the baby. we are taking out the RBCs from the circulation. RBCs are getting destroyed. Now, whenever the RBCs are getting destroyed because of the severe anemia, okay, there is this hyperdynamic circulation. Now, blood is more mobile, more liquidy, heart is pumping more. So, because of this hyperdynamic circulation, guys, if you don't know how, what is the pathophysiology, that's a totally different topic. See, severe anemia can lead to hyperdynamic circulation. Okay, the dynamics of the blood circulation is changed. Now, blood is rushing, heart is working more and more. Okay. Now, severe anemia can lead to hyperdynamic circulation. Now, let me ask you one thing. During hyperdynamic circulation, heart is working more or less? Heart is working more. Now, when the fetal heart is working so much, there is a chance that it can fail. If heart is failing, there is accumulation of blood everywhere in the body of the fetus. So, please concentrate. This hyperdynamic circulation can lead to high output cardiac failure. So, whenever there is high output cardiac failure, blood is not in circulatory process, blood is getting stagnant. Now, such a stagnant blood, venous congestion, such a stagnant blood helps in development of increased hydrostatic pressure. Okay, whenever there is venous stasis, we know there is increased hydrostatic pressure. Whenever there is increased hydrostatic pressure, automatically the plasma is going to ooze out of the capillaries. That leads to edema, right? Yes, because of the increased hydrostatic pressure, there is development of pulmonary edema, or there can be ascites, there can be peripheral edema, generalized edema, that is anasarca. So, baby is getting swollen because of the fluid accumulation in the third space. So, that's known as the hydrops fetalis, the serious complication. So, hydrops fetalis means fetus is developing water accumulation, that is the hydrop, swelling of the baby. So, hydrops fetalis means nothing but baby is getting swollen. Why? Because of severe anemia, hyperdynamic circulation, heart will fail. Whenever the heart is failing, blood will accumulate, blood is going to get stagnant, that increases the hydrostatic pressure, and blood is getting accumulated in the organs and in the third space. So, that is the hydrops fetalis. So, what are the three important complications because of severe anemia, guys? One is kernicterus can happen, erythroblastosis fetalis is seen, and hydrops fetalis is seen. We will discuss much about the hydrops at the end of the topic. Now, there are two more important complications because of the severe anemia. What are they? What all can be seen in this RH isoimmunization? See, severe anemia is going to develop the hypoxic conditions in the baby. Am I right or not? Yes. Now, these hypoxic conditions will lead to placentomegaly. Yes, true. Why? Because see, placenta is the one which is the site for the oxygenation for the baby. Already because of the RBC destruction, hypoxic conditions are getting developed. So, in order to compensate that hypoxic conditions, on one side extramedullary hematopoiesis is happening, on the other side placental size is also getting increased. So, that placentomegaly can lead to pregnancy-induced hypertension. Yes, we have already seen that pregnancy-induced hypertension, it's something, a placental pathology. Because of the abnormal vascular remodeling by the cytotrophoblast, this pregnancy-induced hypertension can happen. So, whatever might be the problem with placenta, that's a risk factor for developing pregnancy-induced hypertension. Now, in this condition, there is placentomegaly. Now, this placentomegaly can lead to pregnancy-induced hypertension in the mother. Mother might develop pregnancy-induced hypertension. Okay. So, this is one problem for the mother. Now, this severe anemia, it is leading to compensatory extramedullary hematopoiesis. We have already seen that. Okay. Now, this compensatory extramedullary hematopoiesis, because of during this process, there can be hepatic dysfunction. Now, you can ask me, why, sir? See, extramedullary hematopoiesis, where it is happening? Extramedullary hematopoiesis is happening in the liver. Now, liver, instead of doing its own duty, it is doing the production of RBCs. Now, the intrinsic functions of the liver are gone. So, what are the normal functions of the liver? It usually have to produce the albumin. Now, albumin synthesis is decreased. Now, it is taking the duty of RBC production. So, that lead to hepatic dysfunction. Hepatic dysfunction means simply it's not producing the albumin. Okay, it's producing less amount of albumin in the baby. Okay, so baby is not able to produce enough amount of albumin. So, that leads to hypoalbuminemia in the baby. Okay, now whenever there is hypoalbuminemia, we all know that albumin is the one which is responsible for osmotic pressure. Okay, see, we all know this thing. See, inside the blood vessels, there is this albumin. Albumin is the one which is helping in maintaining the osmotic pressure, which means this osmotic pressure doesn't allow the plasma to leak out. Okay, albumin doesn't allow the plasma to leak out. So, in the baby, what's happening? Because of the hepatic dysfunction, albumin production is decreased. There is hypoalbuminemia. So, whenever albumin is not there, okay, whenever the albumin is not there, osmotic pressure is decreased. Hydrostatic pressure, the opposite things, the counter things, hydrostatic pressure will be relatively more. That leads to more plasma going out. So, that leads to decreased osmotic pressure. Okay, so decrease not oncotic pressure, osmotic pressure. Okay, now wait. See, this decrease in osmotic pressure is very much important at the level of kidneys. So, that leads to increase the GFR. Okay, whoever have studied the physiology, it's very much easy. It's very much self-explanatory. Whenever osmotic pressure is going down, automatically hydrostatic pressure will be increased. Whenever hydrostatic pressure is increased, automatically glomerular filtration. Okay, it's very much easy for the fluids to leak out, and this fluid is now leaking into the glomerulus for the filtration. So, hypoalbuminemia is leading to decreased osmotic pressure that increases the GFR. So, whenever more GFR means more urine production by the baby. Whenever there is more urine production, that leads to polyhydramnios. Yes, RH incompatibility can lead to polyhydramnios in the baby. True. Okay, so placenta megaly can happen. That leads to pregnancy-induced hypertension in the mother and the baby with RH incompatibility, RH negative mother and RH positive baby, especially the second baby, is going to develop a polyhydramnios. Okay, now after that, let's talk about what exactly is anti-D and how it works. Okay, this anti-D is the one which we use in the clinic. Okay, anti-D. See, what is this anti-D and how it works? Let me ask you one thing, guys. Why all this problem is happening? The problem is because of that, sir. If fetal RBCs enters into maternal circulation, then mother's immune system will be sensitized. Okay, see, let me draw a small image so that it can be very much easy for you. Now, there is this baby. Okay, there is this baby. Now, if baby's RBCs, if they enter into maternal circulation, then mother's immune system will be activated. Okay. Now, baby's RBCs, now it have entered into the mother. This is mother's component and this is the baby's component. This is the placental barrier. Okay. Now, wait. What exactly we are doing? If you can destroy these RBCs immediately, okay, if you can destroy these fetal RBCs immediately, now mother's immune system is not going to be activated. If mother's immune system is not activated, then there is no IgG production by the mother. If there is no IgG production, there is no crossing from the placenta, crossing into the baby. So there is no erythroblastosis fetalis, there is no Hydrops fetalis, there is no polyhydramnios, nothing is going to happen. So, what we can do as a doctors? Okay, if mixing happens, okay, let it happen. But what you can do? You can kill the RBCs, you can kill the fetal RBCs so that they won't sensitize the maternal immune system. If maternal immune system is not sensitized, nothing will be a problem. Okay, so that's what is done by anti-D. Okay, these anti-D injections, that's what their role is. Okay, now let's see one by one what exactly they are doing. Now let's see here. These anti-D antibodies, especially we use them in a dose of 300 micrograms. We will discuss more about this dose later. Now see what these anti-D antibodies are doing. Now we are going to give these anti-D antibodies in IM form, intramuscularly, to the mother. So whenever you give these anti-D antibodies, what they are doing? They will neutralize the fetal RBCs which are RH positive. Now you can ask me why, sir? See, these are anti-D. Anti-D means these antibodies are against the D antigen. Where is D antigen is present? This D antigen is present on the fetal RBCs, sir. Where these fetal RBCs are present now? They are present in the mother, sir. So, the anti-D antibodies, they will neutralize only the fetal RBCs with the D antigen even before they stimulate the maternal immune system. So, there is no maternal sensitization. Whenever there is no maternal sensitization, there is no antibody production by the mother's immune system. Mother's immune system is not going to be sensitized. There is no IgG production by the mother. So, there is no fetal hemolysis. In the current pregnancy or in the upcoming pregnancy, the baby is not going to have any problem. Okay. Now, let's talk a few important direct single liner kind of questions. Now, 300 micrograms can neutralize how much? See, usually this anti-D antibodies, okay, are going to come in a dosage form of 300 micrograms. 300 micrograms is equal to 1500 international units. Now, if you give 300 micrograms, how much amount of fetal RBCs or how much amount of fetal blood will be neutralized inside the mother? See, 300 micrograms can neutralize 15 ml of fetal RBCs or 30 ml of total fetal blood. Okay, if I am talking about fetal blood, it is 30 ml. In that 30 ml, automatic definitely 15 ml will be the RBCs component, right? Okay, blood is nothing but the plasma, RBCs, WBCs, like platelets, all that stuff. So, important point is that if you give 300 micrograms to mother, this 300 micrograms is having a capability to neutralize 15 ml of fetal RBCs or 30 ml of fetal blood. Okay, okay, so well and good. Now, to know whether mother immune system is sensitized or not. Okay, there is this Rh negative pregnancy, female came to you. Now, this is her second pregnancy, for example, or doesn't matter whether it's second pregnancy or first pregnancy. You just want to know whether mother immune system is sensitized or not. Whether the mother have already produced antibodies against the fetal RBCs or not. So, the test done is known as indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test. By performing this indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test, you can know whether mother immune system is already sensitized or not. If mother's immune system is already sensitized, if mother is already making anti-D antibodies, what is the use of you giving these antibodies? There is no use. This anti-D is going to work only if mother immune system is not yet sensitized. If mother's immune system is already sensitized, by herself she is making the anti-D, and that anti-D will cross the placenta and that can kill the baby. So, your anti-D in hospital is going to work only if mother immune system is not yet sensitized. Okay, so you want to know whether mother's immune system is sensitized or not. So, what is the test you are going to do? Indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test you are going to do. Now, if you ask what exactly is indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test, by doing this indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test, you are just checking. You are checking in the maternal plasma MCQ. You are checking the maternal plasma for anti-D antibodies, whether there are any anti-D antibodies in the maternal plasma or not. If anti-D antibodies are present in maternal plasma, means mother's immune system is sensitized. Okay, so see, if this indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test, if indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test is coming positive, it means mother is sensitized. Mother is sensitized, which means she is having IgG antibodies in her blood. Okay, and IgG antibodies against the fetal RBC is present in the blood. If this indirect 𝐒𝐻𝐫𝐢𝐛𝐿 test is coming negative, it means mother is not yet sensitized. You can use the anti-D in her, okay, in her, so that she won't get sensitized. Okay, even if you don't understand, don't worry, everything will be clear in the upcoming slides also. So, at the end of the day, what I want to put into your mind is, we can use anti-D prophylactically. Okay, 300 micrograms of anti-D prophylactically to prevent the maternal sensitization. Maternal sensitization is the worst thing. We just don't want it to happen. And how we are achieving that? We are achieving that by giving anti-D antibodies, to the mother. How much? 300 micrograms. See, now you might get it out. So, we are using anti-D. Okay, mother is not yet produced the anti-D. We are using the anti-D so that this anti-D will go and kill the fetal RBCs in the maternal circulation. Now, you will get it out. So, doesn't this anti-D will cross the placenta and also attacks the fetus? Yes, they do cross the placenta and they can also attack the fetus. But it is such a low dose. It's such a low dose, it doesn't lead to severe fetal hemolysis. Yes, whatever the anti-D antibodies which we are using, they will also cross the placenta from mother into the fetus, but they won't lead to severe hemolysis. They won't lead to severe anemia. Okay, keep that point in mind. Now, let's talk about a very important test which is known as Kleihauer-Betke test. Okay, so Kleihauer-Betke test or acid elution test. Now, what is the use of this test, sir? See, to know the amount of feto-maternal hemorrhage. So, what is the basics? See, basics is that 300 microgram can neutralize how much amount of fetal blood, guys? 30 ml of fetal blood or 15 ml of fetal RBCs in the maternal circulation. Okay, so 300 microgram can neutralize this much amount of fetal blood or fetal RBCs. For example, if the fetal hemorrhage, feto-maternal hemorrhage, if it is, for example, a 60 ml, do you think that 300 microgram is going to be enough? Just think logically. Now 300 microgram of anti-D can only neutralize the 30 ml of fetal blood in the maternal circulation. But for example, there is a lot of feto-maternal hemorrhage. For example, it is 60 ml. Do you think that 300 micrograms is going to neutralize 60 ml? Definitely not. So, to calculate how much amount of anti-D that you have to give, you have to know the feto-maternal hemorrhage first. Okay, let me be very frank here. Usually, it's a fixed dose. Usually in the clinics, 300 micrograms of anti-D antibodies are given. Usually there is no calculation, something like, what is the amount of feto-maternal hemorrhage, and accordingly we are giving like, anti-D. That's the ideal thing to be done. First calculate the feto-maternal hemorrhage by Kleihauer-Betke test. Later calculate the amount of dose, and that particular dose should be given to the mother to neutralize the fetal RBCs. Actually, we are not following that in the clinics, but ideally we have to do like that. Okay, so to find out what is the feto-maternal hemorrhage, we are going to do the Kleihauer-Betke test or acid elution test, and this is a quantitative test. Why this is quantitative? Because by doing this test, we know how much quantity of feto-maternal hemorrhage is happened, how much quantity of fetal blood have entered into the maternal circulation, how much amount of fetal RBCs are present in the maternal circulation. Okay, so this is a quantitative test. Now, by doing this test, what we get, you can be able to calculate the appropriate dose of anti-D should be given to neutralize the fetal RBCs. Okay, now see what is the reagent we are going to use here. The reagent we are going to use here is a citric acid phosphate buffer. Now wait, so what is this reagent? What is all this stuff? Simply, the test is very simple. Take the maternal blood. Okay, take the maternal blood. Okay, this is the slide with the maternal blood. Now, what you are doing? You have taken the maternal blood and you have put it on the slide. Add this acid, citric acid. Okay, add the citric acid. And now, what this acid is doing? See, this acid can act on the maternal RBCs only. Okay, see, this acid can act on maternal RBCs. You can clearly see here, all these are also RBCs. They are pale. This acid can denaturate the hemoglobin in mother's RBCs only. But the fetal RBCs, see, please concentrate here. These bright red or pink color are the fetal RBCs. Fetal RBCs are resistant for the acid damage. Maternal RBCs are sensitive to the acids. So, maternal RBCs are getting eluted. Maternal RBCs are getting eluted, which means hemoglobin is getting denaturated in them so that they lose their color. Fetal RBCs, as they are resistant to the acid damage, they are staying bright red in color. So you can count the number of fetal RBCs present in that proportion of the maternal blood. So you can get an idea or get an estimate. There is whole formula for this. I just don't want you to know all that formula and all the stuff. What we are doing? We are doing this acid elution test, by which at the end of the day we can know how many fetal RBCs are present in that proportion of the maternal blood. So you can get an idea, okay, if you have these many RBCs in that much amount of maternal blood, so this might be the amount of feto-maternal hemorrhage. So if you know this is the feto-maternal hemorrhage, then this will be the dose of anti-D should be given. Okay, see what I am trying to say here is, if you know, for example 30 ml, by doing this Kleihauer-Betke test, at the end you came to know that, okay, 30 ml of feto-maternal hemorrhage has happened. 30 ml of fetal blood have entered into maternal circulation. We all know to neutralize 30 ml, how much amount of anti-D should we have to give? We have to give 300 micrograms of anti-D is required. Okay, let's take one more example. You have done the Kleihauer-Betke test. There you came to know that 60 ml is the feto-maternal hemorrhage, or 60 ml is the amount of fetal blood have entered into mother's blood. Then just think logically and say me, how much amount of anti-D is required? 600 micrograms. Okay, 600 micrograms of anti-D you have to give. Okay, so hope you understand the concept of a Kleihauer-Betke test. It's a quantitative test which tells you how much amount of fetal blood have entered into the maternal circulation. Okay, so by knowing how much amount of feto-maternal hemorrhage, you can calculate the appropriate dose of anti-D that should be given to the mother to neutralize fetal RBCs. Okay, so the reagent which we are using here, the acid which we are using here is the citric acid phosphate buffer. Now we have already seen this. See, maternal RBCs, they are acid sensitive, so HB is going to elute, they become pale in color. Maternal RBCs, they will become pale in color, but the fetal RBCs, they are acid resistant, so hemoglobin doesn't elute, stays red in color. So you can calculate how many fetal RBCs are present in the maternal circulation, and you can calculate the feto-maternal hemorrhage followed by calculating the dose of anti-D. Okay, see here some important direct MCQs. This kind of questions may come in your exams. 300 micrograms can neutralize 30 ml of fetal blood or 15 ml of fetal RBCs. We know this. So that means to neutralize 1 ml, okay, 1 ml of fetal blood, 10 micrograms of anti-D is needed. Just logic, right? See, 30 ml need 300 micrograms. Then 10 ml needs 100 micrograms. 1 ml needs 10 micrograms of anti-D. So to neutralize 1 ml of fetal blood, that is 0.5 ml of fetal RBCs, you need 10 micrograms of anti-D. Okay, so in the same way, example here given is feto-maternal hemorrhage. For example, if it is 60 ml, okay, 60 ml, what is the dose of anti-D required? 600 micrograms. Why? Because 30 ml need 300 micrograms, 60 ml need 600 micrograms. Okay, so this is how you have to calculate the feto-maternal hemorrhage and the dose of anti-D appropriately. I know I have taken a lot of time, but this is highly conceptual. Not all students able to grasp it in a one go. So again, I am repeating. Okay. Now let's talk about the management of RH negative pregnant female. See guys, from here this is very much important. Everything is clinical. Now there is this RH negative pregnant female came to your clinic. Now what you are going to do there? First, you will check the status of the partner, whether the partner is RH positive or RH negative. Okay, you have came to know that the partner is RH positive. Now, what you are going to do? How you are going to manage a female with RH negative pregnancy? RH negative pregnancy means mother is RH negative, baby is RH positive. What you will do is, you are going to perform the ICT, means indirect Coombs test. You are going to do indirect Coombs test by 28 weeks. At 28 weeks, you are going to do indirect Coombs test. Now, if indirect Coombs test is negative, indirect Coombs test negative means what? Mother's immune system is not sensitized. There is no feto-maternal hemorrhage happened so far. Okay, this is first pregnancy only. The first pregnancy I am talking, not even the second pregnancy. First pregnancy, mother is RH negative, partner is RH positive. You don't know, guys, take this point, you don't know whether the baby is RH positive or RH negative. You don't know. So far, you don't know whether the baby is RH positive or RH negative. Mother is RH negative, the partner is RH positive. That's what you know. So what you are going to do? You are going to do the indirect Coombs test at 28 weeks. Now it is coming negative, which means so far the mother's immune system is not yet sensitized, and we don't know whether the baby is RH positive or RH negative. So what we are doing here, give anti-D antibodies, okay, give anti-D antibodies prophylactically, okay. So even if in future, if feto-maternal hemorrhage happens, means immediately this anti-D whatever you have given, they will jump and they will attack the fetal RBCs, so that there is no maternal sensitization. So prophylactically beforehand we are giving anti-D antibodies 300 micrograms IM. Okay, sir, well and good. Why we are giving? To prevent the maternal sensitization, antepartum prophylaxis we are giving. Okay, for example, right now 28 weeks. Who knows, by 32 weeks, because of a trauma, if there is fetal-maternal hemorrhage, can happen, right? By 32 weeks, fetal-maternal hemorrhage can happen, might be because of some trauma. So during that time, fetal RBCs are going to enter into the maternal circulation. So if you give this anti-D antibodies prophylactically, they are waiting, they are present in the maternal blood. So the moment fetal RBCs comes into the maternal circulation, they will jump and they will attack the fetal RBCs, and fetal RBCs are destroyed, so that there is no maternal sensitization. Okay, sir, well and good. Now you have taken the pregnancy till term and you have delivered the baby. Now after delivering the baby, you see that this baby is a RH positive baby. Okay, this baby is a RH positive baby, and you have done the direct 𝐒𝐻 test. Guys, indirect 𝐒𝐻 test is done in the maternal plasma. Indirect 𝐒𝐻 test is done for the maternal plasma to know whether the antibodies are present or not in the maternal plasma. See, direct 𝐒𝐻 test is done on the fetal RBCs. Okay, to know whether antibodies are attacking the fetal RBCs or not. Okay, wait, you have done the delivery. Now what you got? You got a baby with RH positive status, and you have done the direct 𝐒𝐻 test also, and it is coming negative. Direct 𝐒𝐻 test is negative, which means everything okay. Now what you have to do is that you have to give again anti-D 300 micrograms within the next 72 hours after delivery. Within the next 72 hours, you see, it can be given till 28 days postpartum, but best is give within 72 hours anti-D. Why, sir? Why? Because see, during delivery there can be feto-maternal hemorrhage that can happen. Okay, during the process of labor, during the process of delivery, some amount of fetal blood can enter into maternal circulation, and this fetal blood can stimulate the maternal immune system. So what you have to do? You have to neutralize this fetal RBCs. So in order to neutralize this fetal RBCs, again give anti-D postpartum. So this is a postpartum prophylaxis. Why we are doing this postpartum prophylaxis? Why? Because to prevent sensitivity, so that next pregnancy won't be affected. See, already baby is delivered. There is no problem for the current baby. But in order to not to have any problems with the next pregnancy, we are giving anti-D now after delivery. We are giving this anti-D so that mother's immune system is not sensitized, and so that she is not going to make the antibodies. So if she makes the antibodies, these antibodies can attack the next pregnancy, and there can be problems, severe anemia, Hydrops fetalis, erythroblastosis fetalis in the next second baby. So we don't want this to happen. So that's the reason why after delivery again we are giving 300 micrograms. Okay, so this is the postpartum prophylaxis for the next upcoming pregnancy. Okay, so this is what we do usually. Now take the same scenario in a different way. See, if there is RH negative pregnant female to you, now what you are going to do? You are going to perform indirect 𝐒𝐻 test at 28 weeks. Now if it is coming positive means her mother's immune system is already sensitized. Mother is making the anti-D antibodies by herself. Now these anti-D antibodies, they can cross the placenta, they can kill the baby. Okay, so if indirect 𝐒𝐻 test is positive means it indicates mother's immune system is sensitized, she is making the antibodies. Now question is, how much amount of antibodies is she making? If she is making too much amount of antibodies, That's going to be a problem. Why? Because these antibodies can cause severe hemolysis. Severe hemolysis will cause a lot of problems. Severe hemolysis, severe anemia, a lot of complications are going to occur. Hydrops, fetalis can occur. Now what you are going to do, see at 28 weeks, if this indirect comb test, if it is coming positive, check the antibody titer levels in the mother. Okay, check how much amount of antibodies is she making. If she is making antibodies in the ratio of more than 1:16, more than 1:16 means high antibodies, more antibodies she is making. If the ratio is less than 1:16, if the titer is less than 1:16, we are just going to do the regular follow-up. Okay, we are going to do the weekly follow-up. But wait here. If she is making more amount of antibodies in the ratio of 1:16, more than 1:16, you have to think about that these antibodies, these high amount of antibodies, then can cross the placenta, they can cause fetal hemolysis. So what you have to do, check for the fetal anemia, okay, whether there is any severe fetal anemia or not. Okay, so check for the fetal anemia. Fetus is present inside the uterus. How you can know whether fetal anemia is happening or not, whether there is any severe fetal anemia or not. So to know the anemia status of the fetus, what we are going to do is, we are going to measure the peak systolic velocity of the middle cerebral artery. Okay, so the peak systolic velocity of the middle cerebral artery by Doppler. We are going to do, we are going to measure the peak systolic velocity in the baby by doing the Doppler. Okay, now okay, you have done the peak systolic velocity. Now if the value is coming more than 1.5 multiples of median, okay, if the value, the peak systolic velocity in the middle cerebral artery is coming more than 1.5 multiples of median, which means the peak systolic velocity is more, and in which conditions peak systolic velocity will be increased? If the baby is having anemia. See, if the baby is having anemia, automatically the peak systolic velocity in the middle cerebral artery will be increased. So if the peak systolic velocity is more than 1.5 multiples of median, it indicates there is a significant anemia is happening in the baby. Now if there is significant anemia, what we have to do? See, if the period of gestation is more than 34 weeks, fetal lungs are already matured. Okay, more than or equal to 34 weeks, we know that fetal lungs are matured. So what you can do is deliver the baby. Okay, do the delivery. The problem comes when the period of gestation is less than 34 weeks. If the period of gestation is less than or less than 34 weeks, what we can give? Give the steroids to the baby. Okay, give the steroids to the baby, and try to continue the pregnancy. Why? Because fetal lungs are not yet matured. So give the steroids, and to know the exact amount of hemoglobin present in the baby. Okay, we know there is fetal anemia, but how much anemia? Hemoglobin is 10 gram per dl, 11 gram per dl, 8 gram per dl, 9 gram per dl. You have to know, right? So first immediately give the steroids and try to get the exact status of what amount of hemoglobin is present in the baby. So to do that, what we have to do? We have to collect the fetal blood. How you can collect the fetal blood? By doing cardiosynthesis. Okay, so give the steroids, do cardiosynthesis, collect the fetal blood and check the fetal hemoglobin. How much amount of fetal hemoglobin is there? See, if fetal hemoglobin is less than 8 gram per dl, which means very severe anemia. Baby is having severe anemia. We already know the baby is having severe anemia. See, why? Because already the middle cerebral artery, okay, middle cerebral artery Doppler, it's shown that the peak systolic velocity is elevated. We have already seen that the baby is having severe anemia. But how much severe? If fetal hemoglobin is less than 8 gram per dl, this is very much severe. Okay, see, actually you have to deliver the baby, but in this condition, the fetal lungs are not matured. So what you have to do? So in order to prevent this pregnancy, you have to do the transfusion to the baby in utero. In utero itself, you are transfusing the blood to the baby. Okay, because there is severe hemolysis, severe anemia. So you have to do the in utero transfusion. Try to do the in utero transfusion, give steroids and continue the pregnancy till 34 weeks and do the immediate delivery. Okay, so this is what the protocol which we usually follow for Rh negative pregnant females. Okay, so let's talk about Rh negative pregnant female with the history of hydrops. Now you are having Rh negative pregnant female in your clinic. but her previous pregnancy was complicated with the Hydrops fetalis. Okay, the baby is dead. Previous baby is dead with the Hydrops. Now what you have to do? See, same. Perform the see, this is the same protocol. Usually this is the same protocol. What we will do is at 28 weeks perform the indirect 𝐶UM test. If it's coming positive, see, this is what we have to do. Like in the previous slide, we have already discussed this. This is what we have to do. But if the female is RH negative with the history of Hydrops, usually we will skip this test, okay, or we will skip this stage. See, at 28 weeks, you have done the indirect 𝐶UM test and now it came positive. Don't check the antibody titer levels, how much amount of antibodies are there. Don't check the antibody titer levels. Directly measure the peak systolic velocity in the middle cerebral artery of the baby. Very important clinical question. RH negative pregnant female with the history of Hydrops came to your clinic. You have done the indirect 𝐶UM test at 28 weeks. Indirect 𝐶UM test is coming positive. If indirect 𝐶UM test is coming positive, usually what we do is measure the antibody titer levels. But in this case, don't do that. Don't go and measure. Don't go and time waste all these things. Skip antibody titer levels. Directly do the peak systolic velocity of the middle cerebral artery. If it's coming more than 1.5, rest is the same. Okay, rest is the same. Even in this condition, the rest protocols is exactly the same. Now, after doing this, now let's discuss what are the other conditions where we can use this anti-D. Where else we can use this anti-D antibodies? See, so these anti-D antibodies prophylactically we can use in the condition of RH negative pregnancies. Other than this RH negative pregnancies, we can also use this anti-D in certain other conditions also. Where, sir? Wherever there is possibility of feto-maternal hemorrhage, wherever there is a possibility of a feto-maternal hemorrhage, or wherever I can say there is possibility of a fetal blood mixing with the maternal blood, wherever there is such a possibility, in all those conditions you can use anti-D antibodies. 300 micrograms of anti-D antibodies can be used in all those conditions. So what are those conditions, sir? See, amniocentesis is possible, right? During amniocentesis or during chorionic villus sampling, during ectopic pregnancy, or after abortions, after delivering a RH positive baby, like there is possibility that this is a normal pregnancy, that some amount of fetal blood have mixed with the maternal blood. So this condition, and unexplained vaginal bleeding or abdominal trauma, abruptio placenta, in all these conditions, you can use anti-D antibodies. Anti-D prophylaxis can be used in all these conditions if mother is not yet sensitized. Okay. See, at approximately 28 weeks of gestations, have we discussed or not? Yes, in a RH negative female, at 28 weeks of period of gestations, we are going to do the indirect 𝐶UM test. If it's coming negative, definitely we will give anti-D antibodies. Without any doubt, we are going to give that. So, at the end of the day, what I want you to remember is that all of the following conditions are the indications for anti-D prophylaxis, except that kind of questions are possible. So, you should know amniocentesis, chorionic villus sampling, after abortions, after trauma, or after external cephalic version. Please take here also one more point, external cephalic version. After the external cephalic version also you have to give anti-D. Okay, unexplained vaginal bleeding, MCQ. After unexplained vaginal bleeding, after delivering the RH positive baby within 72 hours, you have to give RH antibodies or anti-D antibodies prophylactically you have to give. Okay, now let's talk about Hydrops fetalis. We all know this Hydrops fetalis is a complication of a severe anemia. Okay, it's because of a severe anemia, fluid is getting accumulated in the baby. Okay, you can clearly see here the baby is getting swollen. Okay, baby is getting swollen in all the body cavities, fluid is getting accumulated. So to define Hydrops fetalis, fluid should be getting accumulated in more than 2 body cavities. Out of the 4, here I have given you the criteria. Out of this 4 body cavities, at least in 2 body spaces the fluid is getting accumulated. So if the baby should be having ascites, pleural effusion, pericardial effusion, scalp edema or subcutaneous edema. Out of these 4, at least 2 should be there. If 2 should be there means, if 2 are there means, we can say that there is Hydrops fetalis is happening in the baby. Usually Hydrops fetalis is not compatible with the life. Okay, there are very few cases where, like, Hydrops fetalis, like, you can have a live baby, but in most of the cases this Hydrops fetalis is not compatible with the life. And see, if you do the investigation of choice, to know whether the Hydrops fetalis is happening or not in the baby, you have to do the ultrasonography. Okay, transvaginal ultrasonography is the investigation of choice. Whenever you do, that's an MCQ, guys. Okay, whenever you do transvaginal ultrasonography, you look at the scalp. You can look at the scalp over here. This is the scalp, and surrounding the scalp you have this edema, fluid accumulation. So around the head you are having a halo. Okay, around the head you are having a halo. This gives you halo sign. Okay, halo sign or Buddha sign. Okay, halo sign are around the head. Okay, around the head of the baby, because of this fluid accumulation, like, there is this halo which is present over the scalp or the head, that is halo sign or Buddha sign, which is seen with the Hydrops fetalis in transvaginal sonography. Okay, and I am again repeating, Hydrops fetalis is a severe complication because of fetal anemia. Okay, now this Hydrops is of 2 types: immune Hydrops, non-immune Hydrops. See, immune Hydrops means immune system, because of the immune system dysfunction, maternal immune system is getting sensitized. So maternal immune system is producing IgG antibodies. They are coming to the fetus, they are destroying the fetal RBCs, leading to severe anemia, Hydrops fetalis. Okay, so RH isoimmunization or RH incompatibility is a condition of immune Hydrops. Example of immune Hydrops is RH isoimmunization. If there is no role of immune system, it means non-immune Hydrops. Non-immune Hydrops means Hydrops is happening in the baby, but there is no role of immune system. Immune system is not responsible for Hydrops fetalis. So what they see, any condition which is associated with severe fetal anemia, for example thalassemia. See, thalassemia is not because of the immune dysfunction. So thalassemia, very important. Thalassemia or anything which is associated with the high output cardiac failure, anemia, sacrococcygeal teratoma, MCQ, sacrococcygeal teratoma is an example for non-immune Hydrops. It leads to non-immune Hydrops, MCQ, fetal adrenal neuroblastoma, and cardiovascular defects. If heart is failing, fluid accumulates in the baby. So tetralogy of Fallot in the baby, tetralogy of Fallot, and infections, parvovirus B19 infections. We all know that parvovirus B19 it is associated with the pancytopenia. Okay, a severe anemia can happen in the baby. Whenever there is severe anemia, that can lead to high output cardiac failure, hyperdynamic circulation, that leads to fluid accumulation in the baby, Hydrops fetalis. And twin transfusion syndrome, yes, we have discussed this. Okay, twin transfusion syndrome, one baby is going to have a polycythemia and one baby is going to have anemia. Okay, both the babies are going to die. So even in twin transfusion syndrome, one baby is going to develop anemia, and anemia can lead to hyperdynamic circulation, high output cardiac failure, and the baby can die. Okay, and cystic hygroma, MCQ, cystic hygroma can lead to non-immune Hydrops, very important. And chromosomal anomalies like Turner syndrome and congenital nephrosis, if kidneys are failed, okay, the kidneys are having a problem, that can also lead to non-immune Hydrops. So the MCQ points which I want you to remember here, see what, like all of the following conditions are associated with the non-immune Hydrops, except the kind of questions that will be coming. So very important points: sacrococcygeal teratoma, cystic hygroma, twin transfusion syndrome, parvovirus B19, congenital nephrosis. Okay, they are very much important conditions which are associated with non-immune Hydrops. And immune Hydrops example is RH incompatibility. Mother is RH negative, and the baby is RH positive. That can lead to severe fetal anemia, leads to Hydrops fetalis. Okay, now here you can see that there is this baby who is having, like, edematous body, like in ascites is very clearly visible, like, anasarca is also seen. But what is this? We have already discussed that sacrococcygeal teratoma. Yes, this is sacrococcygeal teratoma. Just by looking at, like, the baby, you can say that this baby is having sacrococcygeal teratoma, and the sacrococcygeal teratoma can lead to Hydrops fetalis, and this baby is also having this very much fluid accumulation in the abdomen, and the scalp is also edematous. Okay, this is also non-immune hydrops. How can I say that? Why? Because here the baby is having cystic hygroma. Okay, cystic hygroma babies are going to have non-immune hydrops, and sacrococcygeal teratoma can also lead to non-immune hydrops. Okay guys, I hope I have cleared the topic of RH incompatibility or RH isoimmunization. I have done my best. Okay guys, thank you. Have a nice day.